Hey boot campers, welcome back to another video. This is David, your guide to gastroenterology, and today we're going to be continuing our pharmacology chapter talking about antacids. Now, we already talked in our previous video about H2 antagonists like famotidine, which work on our H2 receptors right here, preventing activation of them via histamine from our enterochromaffin-like cells, and therefore preventing the CAMP pathway from activating our hydrogen potassium ATPase, aka our proton pump. Meanwhile, our proton pump inhibitors we discussed prevent activation of that proton pump in general. Meanwhile, the mechanism of action of our antacids is to directly neutralize that hydrochloric acid. Antacids are as basic chemistry can get. However, they do also decrease pepsin absorption and activity, so their action isn't solely limited to this neutralization of hydrochloric acid, as we can see right here. Of course, I wasn't going to let you get through this video without some basic chemistry. So what I'm going to do is very briefly go through our three major antacids and discuss how exactly they break down hydrochloric acid. So first off, we have aluminum hydroxide, which is one of our big three. Aluminum hydroxide is going to neutralize 3 hydrochloric acids and turn them into 3 waters, and then aluminum chloride. Then magnesium hydroxide right here is going to take 2 hydrochloric acids and become magnesium chloride. Meanwhile, our final one, calcium carbonate, is going to take another 2 hydrochloric acids and become calcium chloride right here. And if the names aluminum hydroxide, magnesium hydroxide, and calcium carbonate sound familiar, it's because these are in a lot of very commonly used products. For example, calcium carbonate, which is a major ingredient in Tums. And now that I've said Tums, you're probably aware that the clinical use for these antacids is flares of GERD, as opposed to proton pump inhibitors, which are much more of a chronic control medication. Antacids are clinical uses for flares of GERD. However, these antacids aren't just used for flares of GERD and gastritis. We can also use them for other things, including aluminum hydroxide is used as part of a mouthwash for chemotherapy-related mucositis. And aluminum hydroxide causes constipation. Therefore, aluminum hydroxide can be used in patients with too much diarrhea. Meanwhile, magnesium hydroxide has the opposite effect and causes diarrhea, and therefore can be used for people with GERD as well as constipation. Now, because antacids are quite literally neutralizing their bases, they're neutralizing acid, because of that, all of these antacids can affect drug bioavailability and renal excretion via pH alteration. A notable one for this is going to be tetracyclines. You hear people say, don't take your tetracyclines with milk. Similarly, don't take your tetracyclines with antacids. Very similar principle, a combination of chelation and pH alteration are going to prevent your tetracyclines from properly working. In addition to that general drug bioavailability side effect, we also see aluminum hydroxide have some specific side effects, including decrease in potassium, decrease in magnesium, and a decrease in phosphate, which makes this the antacid that you need to be most cautious about when it comes to patients with renal insufficiency. Especially in patients with renal insufficiency, this drug can lead to seizures, encephalopathy, and osteomalacia. Meanwhile, calcium carbonate comes with its own set of adverse effects, including hypercalcemia as well as milk alkali syndrome. And milk alkali syndrome, despite being a pretty fun-sounding name, is a combination of hypercalcemia, metabolic alkalosis, as well as acute kidney injury. And the real concern here is that if left untreated, milk alkali syndrome can lead to metastatic calcification, which means that things that aren't normally supposed to be calcified are calcified. Another thing you can see with calcium carbonate is going to be rebound acid production. And while you can see rebound acid production with a lot of these different drugs, including our H2 blockers, calcium carbonate is one that's notoriously known for rebound acid production. Our final main antacid, magnesium hydroxide, can lead to hyporeflexia and hypotension stemming from the magnesium input, as well as, very importantly, a decrease in potassium or hypokalemia, as well as arrhythmias. And this is a pretty high yield thing to be aware of, because the majority of the time we're talking about magnesium, it's actually typically in favor of increased cardiovascular health and decreasing arrhythmias. So it's important to be aware that magnesium hydroxide can increase your risk for arrhythmias. And if you're interested in learning more about the intertwined linkage of magnesium and potassium absorption, I highly recommend you check out our renal videos, which are also taught by an excellent David. So to briefly cover what we talked about in this video, our antacids directly neutralize our hydrochloric acid. They're also going to decrease pepsin absorption and activity, but the mainstay of this treatment is to neutralize the acid directly. They're used for flares of GERD and gastritis, and you should not be taking antacids throughout the course of the day, in part because one of these antacids is known for giving constipation, while the other is known for causing diarrhea. And the third one of these, calcium carbonate, can cause hypercalcemia or milk alkali syndrome if taken in excess. All of these different antacids are going to affect drug bioavailability and renal excretion via pH alteration, especially tetracyclines. And a very important thing to be aware for magnesium hydroxide is that it can cause, among other things, hypotension, hyperreflexia, as well as hypokalemia and arrhythmias. That's it for this video. I hope you all enjoyed it, and I'll see you in the next one.